Hello, my name is Amanda Rantilla. I'm an occupational therapist completing my post-professional capstone. My topic for today is current practices of clinicians working with children with significant feeding challenges. I chose to focus my capstone research on feeding in children, specifically children with an autism diagnosis or developmental delay. We know that feeding is one of the primary occupations for children. However, feeding does come with its challenges. Feeding challenges affect 5 to 20% of the general pediatric population. This percentage increases to 40 to 80% when considering children with disabilities. Studies have found that up to 90% of children with an autism diagnosis experience feeding challenges. With so many children affected by feeding challenges, it is no wonder that occupational therapists are being asked to address this. However, how are they addressing this? What interventions are they using? As an occupational therapist practicing for 8 years, I have attempted some light research on this topic to find interventions and best practices for my clients. Surprisingly, there is limited evidence for feeding interventions for children with significant challenges. Significant challenges could include an extremely limited diet or intensive behavior surrounding mealtimes. This research narrows even more when considering children with an autism diagnosis or developmental delays. I was curious if I was alone in feeling that the research was lacking for this specific population. I knew there must be other therapists out there who were working with similar clients and facing similar concerns. This curiosity led me to the main purpose of this capstone: to talk with clinicians currently working with this population on feeding, to understand what supports they are finding, what barriers they are encountering, and how they feel they are able to support this population. Before reaching out to current clinicians, it was important to examine what the literature said about feeding interventions in children. I have broken down the literature into several themes. The first part of the literature reviewed sensory interventions for feeding. These sensory interventions did not focus on a specific diagnosis, but rather approached feeding from a sensory perspective. Esposito et al. Completed a literature review on various sensory interventions. They noted a positive increase in food intake when children were introduced to food smells prior to feeding. However, they found that overall, research focusing on the use of sensory interventions was rare. Therefore, they could not determine a best practice approach when using sensory strategies for feeding. Another prominent piece of the literature is the sequential oral sensory, or SOS, approach. This focuses on a developmental path of moving through a hierarchy of trying new foods. Within the initial trials, there was no mention of a specific diagnosis or delays. The initial trials of the SOS approach demonstrated a positive effect in increasing food intake in children. However, there have not been many long-term or larger studies on the effectiveness of the SOS approach. One long-term study that was completed was by Benson et al. They conducted a retrospective analysis of children who received a modified SOS approach over the course of 1 to 2 years. These participants had significant feeding challenges and delays, which required the modification of the SOS approach. The modification included the length of time, as SOS is typically delivered over a 12-week period rather than 1 to 2 years. They found that half of the participants had no positive trend in consistently increasing food intake. 36% of the participants started to see a positive trend towards the end of the treatment period for some foods. However, it had not been sustained long enough at that time to truly be considered a positive trend. 14% of the participants had a definite positive trend. A newer sensory feeding program called MealSense focuses on parent training from a sensory integration perspective. The initial study had expert evaluators review the program for how well it aligned with the AIR's sensory integration approaches and how well it integrated best feeding practices. The experts concluded it did both well. Parents also reviewed the program for accessibility and usability. They agreed that the program was both accessible and user-friendly. At this time, this program does not have any published studies where MealSense has been implemented with a pediatric population. The literature also reviews behavioral interventions. Reynoso et al. Examined differential reinforcement of alternative behaviors, or a DRA. They found that the DRA worked only if certain parameters were met, including the inclusion of parents and having the child understand contingencies. Within their review, they discussed how DRA protocols have been around longer than sensory-based protocols and therefore have more research. However, even with more research, Reynoso et al. Only noted short-term effects in increasing food consumption. Rohacek et al. Provided parent training through a behavioral lens to decrease challenging behaviors and improve feeding. This was done through 6 weekly parent meetings that lasted 2 hours each. The focus was on various behavioral techniques, including praise, differential reinforcement, and antecedent consequent strategies. Weekly topics included parental attention, effective praise, managing challenging behavior, strategies for sleep, strategies for feeding, and a review of all topics. While the topics from the sessions may have been applicable to many situations, there was only 1 week with a specific focus on feeding. The results of the training showed no statistically significant improvement in feeding challenges based on this parent training. Hodges et al. Also reviewed caregiver training in their literature review. A majority of their findings were from day programs or inpatient programs, which allowed for a 5-day-a-week sessions or multiple meals per day with a feeding therapist. They noted positive correlations when parents were involved in these interventions, increasing carryover of skills. While there were positive outcomes, it should be noted that this intervention delivery schedule was more intensive than most typical feeding therapies, and therefore may have different results if carried out on a less frequent schedule. 2 other articles played a role in the literature review of current interventions. Beaudry-Belfieux et al. Determined that a strong intervention method was utilizing a multidisciplinary team, where each professional could provide expertise within their scope. Their proposed team included a gastroenterologist, other medical specialists, an occupational therapist, a psychologist, a speech therapist, and a nutritionist. While a multidisciplinary team might be ideal, it is often difficult to assemble and utilize in practice. A multidisciplinary team may be more accessible to clinicians who work in a hospital setting where all of these professions might be employed. However, it would be more challenging in an outpatient clinic, which may only have 1 or 2 of these specialties. A multidisciplinary team may also not be available due to lack of professionals in the area. In small rural towns, medical specialists may not be able to engage in treatment for a child. Chilman et al. Completed a survey of current feeding practices of clinicians in Australia. The clinicians noted that parent coaching was the most commonly used intervention. While the article was able to determine the most used interventions, it did not determine the effectiveness of these interventions. It is useful to know what interventions clinicians are using. However, it is also essential to review the efficacy of these methods. The literature review demonstrated some significant limitations. One large limitation is that many of the studies utilize small sample sizes. They also lacked studies that demonstrated long-term effects. Studies with sample sizes that are small and short-term effects are strong starting points. However, it is challenging to know if these interventions work for the larger population and maintain the skills gained. Another limitation was the lack of specific demographic information. While details such as age and diagnosis were included, specific feeding challenges often were not. Were these children experiencing a significantly small food inventory? Did they have significant behaviors at mealtime? The studies also did not address the developmental level of the children, which would greatly impact the delivery of the intervention. There also appeared to be a lack of acknowledgement from many sources that feeding is a multi-factor occupation. Very rarely are feeding challenges due solely to sensory concerns or behavioral concerns, but rather a combination of factors. Many studies focused on one lens or the other when providing interventions. Overall, the literature lacked concrete evidence for feeding interventions, specifically for children with significant feeding needs who have an autism diagnosis or developmental delays. This lack of evidence is challenging because clinicians are taught to review literature to ensure that they are providing evidence-based care. If there is limited literature, how can clinicians provide the most effective care? With a lack of literature, what are clinicians currently doing? The best way to answer this question was to ask. This capstone utilized a mixed methods approach to gather as much information and insight as possible from current clinicians. An initial survey was distributed through social media groups and email, using a snowball method to gather participants. Clinicians completed the survey to both determine eligibility for the focus group and collect demographic data for focus group participants. Eligibility criteria included the following: clinicians who work in outpatient settings, schools, or similar settings, excluding hospitals or medical settings. Clinicians who work with children with autism or other significant challenges who present with severe feeding challenges, and clinicians who have worked on feeding with this population for at least 3 months. In addition to the children having severe feeding challenges, the population also needed to have some developmental delays, language delays, and/or challenging behaviors. 15 responses were gathered from the survey with 14 eligible candidates. One candidate was ineligible due to working on feeding for less than 3 months. Of the 14 eligible candidates, 6 confirmed their attendance for the focus group and participated. In the focus group, participants were asked guiding questions throughout, and clarifying questions were posed based on the participants' discussion. This allowed participants to lead the discussion and respond to each other's comments. This study was reviewed and approved by the Elizabethtown College Institutional Review Board. The next sections represent the demographics and responses from the participants of the focus group. 5 of the 6 clinicians in the groups were occupational therapists, with 1 occupational therapy assistant participating. Most clinicians were from the New England area, specifically Connecticut and Massachusetts, with 1 clinician from Texas. 60% of the participants had 1 to 3 years of feeding experience, with 20% of participants having more than 3 years experience or 6 to 12 months of experience. Half of the participants worked in outpatient settings, with 2 clinicians working in home health and 1 working in a school. The majority of clients seen by the participants were ages 3 to 12 years old. Some clinicians saw children as young as birth or as old as 18 plus. All clinicians noted seeing children with autism diagnosis. A majority of clinicians also worked with children with some form of sensory processing disorder. Additional diagnoses include ADHD, medically complex children, children with Down syndrome, and children with developmental delays. All clinicians noted that they saw children with severely limited food diets, which are diets consisting of less than 15 foods, children with intense behaviors, for example, throwing, hitting, or biting at mealtimes, and children using utensils significantly below their age level, for example, drinking from a bottle at age 5. Other concerns noted were severely limited food behaviors or routines, for example, only eating out of the same bowl, and a largely liquid diet without medical necessity. While these demographics represent the participants of the focus groups, it should be noted that a larger group completed the survey. The larger group also noted facing the challenges listed above. This demonstrates that clinicians across the country are working on feeding and encountering the challenges listed here. Next, we will review the results of the focus group discussions. 4 main themes emerged from the discussion within the focus group. The first theme was the prevalent use of social media. The clinicians reported turning to social media rather than literature for intervention planning. Clinicians also described using a multi-factor approach to their feeding interventions. They explained that they utilized sensory, behavioral, and developmental lenses simultaneously when working with clients. Clinicians all noted limited resources available to assist with feeding. These included both monetary constraints and insufficient time. The fourth main theme that emerged was the importance and the challenge of parent buy-in. All clinicians agreed on the importance of parent buy-in. However, they also recognized the difficulties in gaining and maintaining this buy-in. The first main theme was the use of social media. It was surprising to me that so many therapists were turning to social media for resources for treatment. They appreciated that social media had quick, digestible ideas. The most referenced social media platform was Instagram. Some quotes from therapists included that the app is free and it's more transferable to give it to parents. As mentioned, one of the themes was limited time and funds, which makes a free app with quick ideas very attractive. Social media is a relatively new resource for consuming knowledge. Often, ideas for interventions can be found while scrolling mindlessly. This easy access to information is, on one hand, nice to have. Gone are the days of spending hours searching for articles when you can review a 30-second video of a creative intervention. On the other hand, there is currently very limited research on the efficacy of social media as an evidence-based practice. Based on a small literature review, most of the literature focuses on how large organizations can utilize social media. For example, an article by Yunusa Nakun et al. Noted the use of Twitter to provide health information to young Black and African American women. This is an example of using a formal system to provide health information to others. Some studies found that clinicians are interested in using social media as a platform for continuing education. However, they are unable to determine the value of the information provided. Oftentimes within the focus group, the participants were referring to singular social media accounts rather than large organizations. With the focus on individual social media accounts, it is essential to determine if the information provided is evidence-based. Moving forward, this would be a key area of research, not just for feeding, but for interventions across domains. Another theme that emerged was the use of a multi-factor approach. Clinicians noted the importance of focusing on regulation and behavioral aspects in relation to feeding. One clinician stated, "You have to work on the regulation piece to address the behavior, and then hopefully get back on track to the feeding." This quote referred to working with children who might exhibit significant behaviors, such as yelling, hitting, or throwing during mealtime. As occupational therapists, we understand how crucial it is for a child to be regulated before learning a new skill or engaging in a challenging situation. Clinicians also highlighted the use of sensory strategies, including playing with different textures to prepare children for feeding interventions. One clinician described using a sensory approach, saying, "A lot of them are very tactily defensive," and shared examples of using glue, Play-Doh, and other textures to prepare for specific feeding interventions. Research has shown that a multi-factor approach can be beneficial when addressing feeding challenges. However, most literature emphasizes the use of a multidisciplinary team rather than a single professional managing multiple lenses. Of the literature reviewing specific interventions, most articles focused on one type of intervention, behavioral or sensory, rather than a combination. It should be noted that clinicians are independently compiling this multi-factor approach. They are creatively combining strategies from various approaches. While this method may achieve results, it takes a lot of time and effort to pull together a personalized feeding program that combines multiple perspectives. Another theme that arose from the focus group was the lack of resources. These resources could be categorized into monetary resources and time resources. Clinicians agree that continuing education courses were expensive. When asked which courses they found helpful or whether cost was a barrier, one clinician stated, "The ones that seem very helpful are normally very expensive." This financial barrier was one reason clinicians reported turning to social media for treatment ideas. Clinicians also noted that food resources presented another challenge. They discussed how they were often buying the food themselves and their clinics did not provide adequate funding. One clinician said, "I'm buying all the foods myself to give the kids exposure," while another added, "We don't have the funding in our clinic." These monetary challenges extended to the families as well. A clinician working in home health referenced working in settings where food insecurity was a significant concern, saying, "Families can be hesitant or unable to purchase food their child may only take a bite of or refuse." This lack of resources for both clinicians and families hindered their ability to provide consistent and effective feeding therapy. In addition to monetary resources, clinicians cited a lack of time to adequately review feeding evidence and prepare interventions. All 6 clinicians noted that they were spending time outside of work to prepare for feeding sessions. 2/3 of the group noted that feeding took up more time outside of work than other goal areas, such as fine or gross motor skills. One clinician commented, "I would need another 8-hour workday to review the research for best feeding practices." While clinicians recognize the importance of staying current with the evidence, they acknowledge that it was time-consuming to keep up with the growing body of research. Another clinician remarked, "It's a lot to keep up to date with new things because things are changing all the time. And it's crazy. It's a lot of work outside of work." Following these discussions, a small literature review on work-life balance for occupational therapists was conducted. Research indicated that performing work tasks outside of regular hours increases the risk of burnout. Specific stressors for occupational therapists included limited time and resources, which reinforced the concerns raised during the focus group. The fourth main theme discussed was parent buy-in. All clinicians agreed that gaining parent buy-in was essential for meeting goals and maintaining progress. However, they noted that getting parents to follow through with bringing in food items or completing tasks at home was challenging. One clinician described the extensive preparation for feeding sessions, which included calling parents ahead of time. Despite these efforts, the clinician said, "We have nothing for a feeding session, and you can't do feeding sessions if you don't have what you were supposed to be working with." Some clinicians cited cultural differences as factors that required additional time and consideration. They also highlighted the importance of meeting parents where they were in order to gain the most buy-in. This included collaborating with parents on feasible activities to try at home to promote carryover and maintain progress. Clinicians agreed that they wish they had more time and resources to find better parent education materials to help gain and maintain buy-in. While the focus group developed 4 strong themes regarding feeding interventions, there were some limitations in this study. The focus group was small, consisting of only 6 clinicians. Based on the original survey, these feeding challenges were not unique to these 6 participants. However, completing focus groups with a larger sample size would provide further insight and allow for additional themes to emerge. Future research on the use of social media is also needed. The literature review for this study focused on research studies, articles, and formal feeding protocols. Gaining more insight into the use of social media as an evidence-based resource, particularly individual accounts, and whether the interventions they provide are evidence-based would be valuable. Moving forward, it is important to begin developing a multi-factor feeding approach that can be delivered by a single profession. Both the clinicians in the focus group and the literature discuss the benefits of a multi-factor approach. However, having a single cohesive program would reduce the workload and potentially decreasing burnout, eliminating the need for clinicians to piece together information from various sources. Overall, there is a high prevalence of occupational therapy practitioners working with children with significant feeding challenges. Clinicians often turn to social media for treatment ideas and piece together a multi-factor approach. These social media accounts may not be evidence-based, and creating a multi-factor approach requires significant time and effort. Clinicians identified funding and time constraints as barriers to intervention planning, both of which can contribute to burnout. They also noted challenges in gaining and maintaining parent buy-in, which is essential for carryover and maintaining progress. There is a distinct lack of comprehensive research on feeding interventions for children with significant feeding challenges. This gap makes it difficult for clinicians to determine the best course of action. Moving forward, expanding research and providing more detailed, evidence-based information would benefit clinicians, families, and organizations. This would allow clinicians to deliver more effective feeding interventions for children with significant feeding challenges. Thank you. And here are my references.